also all those who are involved in preparing the abstract and who are more involved in the implementation of the program I'm going to talk about. It's just unfortunate that Felicia was not able to come at the last minute, so I do hope that I will do some justice to this brief presentation. So the presentation is on reducing HIV-related maternal mortality through community system strengthening. It is a program that was implemented by the International HIV/AIDS Alliance. It was implemented across 4 countries: Kenya, Uganda, South Sudan, and Zambia. And I think for most of you who are in this room are aware that though in all those countries HIV prevalence rates are high, they're also, the 4 countries are also countries that have high maternal mortality rates that range between 435 to close to 2,000 per 100,000 live births. The program itself was implemented over a very short period, a 12-month period, which is really short. But it did have some results which, or at least findings, which we thought would be important to share with those involved in program implementation and program design. It aimed at reducing HIV-related maternal mortality and improving health outcomes. The program also really aimed at addressing both the demand and supply sides of the health system. What the program did is it involved a cross-section of I would say community players in the actual implementation. It involved training various community health workers, traditional birth attendants, community health workers, peer educators, religious leaders, and other community leaders overall in creating awareness and mobilizing the community to create demand and utilization of the health services within the communities. It also focused quite a bit on policy and advocacy. And in order to do that, it worked through national partnership platforms that are really made up of civil society organizations and focus on working together, sharing dialogue, exchanging with each other on issues that are relevant or affect them as community members in their communities. And collectively, they all aim at working and raising those issues with their leaders at a district level, provincial level, right up to the government level. So it was both program implementation, but also policy and advocacy change. Part of the advocacy work also involved working with what we call key correspondents. These were really young people, lay people who are interested in documenting some of the issues as they went along and using some of that documentation to share with the larger civil society organizations, so some of those issues could be brought to the decision makers within the countries where the program was implemented. Now, while it covered 4 countries, the program itself, there were of course slight differences from in each country based on the actual country context. However, the program itself really had some 4 standardized components. It really looked at, as I mentioned, increasing demand for health services, and did this really by working with the various community workers, as I said, providing them with the information and awareness and encouraging them, particularly women, pregnant women, and a particular focus with women living with HIV, to at least seek antenatal care services, and also to get to understand what are the key danger signs and the importance of the linkage between antenatal care and maternal mortality and HIV. The program also focused on developing a strong referral system within the community, a referral system that really ensured that those in need of services, particularly the women, pregnant women, women living with HIV who are pregnant, but also their male partners and young people, to really seek services as and when they needed them. The 4th component was capturing frontline perspectives about the burden of HIV and maternal mortality and the linkages between the two. And key to capturing that information were the key correspondents that I mentioned, the young people who are really key, who are young journalists, and not trained journalists, but those who are just interested in taking part in this particular program. And then the fourth component across the 4 countries was building a more enabling policy environment for integration, and that was through the national partnerships platforms that I mentioned. Now, as I said, it was a brief project. It's lasted only 12 months, and of course, when you're carrying out a 12-month project, you really lose a number of 2 or so months at the beginning and at the end. But there were a few key results that we wanted to share with you this afternoon. One of the key results was the improved knowledge and awareness of MCH, HIV, and sexual and reproductive health issues among community members and frontline health workers. Throughout the program, over 120,000 people were reached. These included, as I mentioned, traditional birth attendants, community health workers, peer educators, young people, women in need of, pregnant women in need of services, their male partners, who are given the information on the linkages between maternal mortality and HIV, and the importance of seeking antenatal care in the communities where they lived. A second key finding was the increased number of pregnant women attending the antenatal care services and opting to deliver at health facilities. Throughout the duration of the program, there were at least over 81,000 referrals, pregnant women who were referred for various services at the health facilities. One of the key things that was a key reporting by some of the health facilities was that a lot of the women who attended, particularly those who are living with HIV, were able to successfully deliver babies who are healthy and HIV negative. A third key finding was the increase in male involvement, supporting voluntary counseling and testing, and disclosure between intimate partners. As the program progressed, one thing we noted was that increasingly men were quite interested in supporting their female partners in the pregnancy journey, accompanying them to the ANC clinic and just supporting them through the process. And as reported by some of the health workers, is that men who accompanied their female partners, they were oftentimes quite willing to take a HIV test when it was offered to them, which was very helpful not only in them knowing their status, but also in terms of disclosure between partners. The fourth finding that I wanted to share with you, which is really the last finding I wanted to share, was the National Partnerships Platform model, which leads to greater engagement and buy-in from government and increased coverage of MNCH, HIV, and SRH issues. The National Partnerships Platforms, as I said, these were not platforms that were set up by the Alliance. They were platforms that civil society organizations themselves had formed. The Alliance simply used existing platforms and helped strengthen them, really to get them to focus on this particular issue of the linkage between maternal mortality and HIV. But what we found very helpful was that these particular platforms, the fact that they met frequently, they were able to exchange what was going on. They had e-forums where they were able to have dialogues amongst themselves and come out with the advocacy issues that they needed to take at a higher level with the community leaders was very effective. And also including sharing or having at least articles in various media in the 4 countries where the implementation took place. Now, in terms of conclusion, I think one of the key findings was really the role that the community workers and civil society organizations as a whole played in mobilizing increasing demand for services and linking those in need of services to the health facilities where they needed the services, particularly the pregnant women, and a particular focus of those pregnant women living with HIV to get the services that they needed. There was also the particular role that they played in creating awareness across the various stakeholders